but also systems that are necessary to inoculate an entire population, whether it be in Ireland, Europe, or globally, in fact. The other side of the equation is the challenge of ensuring vaccine acceptance. So levels of hesitancy vary enormously, as we know, from country to country, and the issues behind them are very different. And that's part of what we wanted to discuss today. I think we need not just the resources of public health officials, but also the insights of historians, of sociologists, and anthropologists to understand this phenomenon and really to work in concert with those who are developing the vaccines. Thank you very much for everyone who signed up for the webinar. We've had over 140 people registered. And today we're very fortunate to be joined by a panel of experts with wide experience in investigating the questions that we're posing. So I'll introduce them in a moment. First, a word about the series itself. This is in fact our 7th session in the RIA series, Perspectives and Pathways in a Time of Crisis. We have convened discussions on the science of COVID-19, on economic questions, issues of social justice, the resilience of the higher education system, lessons from previous pandemics, and then a recent session on vaccines, variants, and critical care. Recordings of these sessions are available on the Academy's webpage. I want to thank once again Jennifer Keneally in the RIA for her help. She's running things behind the scenes, and also to Craig Scarrett of the RIA, who's helping to field your questions. So please do participate, by the way, via chat and Q&A. Those functions are available. So let me first introduce our speakers, and then we'll move to their contributions. First of all, Professor Anita Hardin. She's Professor of Anthropology of Care and Health at the University of Amsterdam. She trained as a medical anthropologist and biologist and has conducted studies of immunization, new reproductive technologies, and AIDS medicines. She received an ERC Advanced Grant for a project on chemical youth that looked at what chemical and pharmaceutical substances, as opposed to illicit narcotics, are supposed to do for youths. She served as scientific director of the Amsterdam Institute for Social Science Research and currently leads the research priority in global health at the University of Amsterdam. Among her many authored and edited books are Chemical Youth, which came out last year, Medical Anthropology Handbook in 2016, and also From Access to Adherence, The Challenges of Antiretroviral Treatment, published by the World Health Organization. She's a member of the Royal Netherlands Academy of Arts and Sciences. Dr. Anne Moore is senior lecturer in biochemistry and cell biology at University College Cork. Her research focuses on vaccine development, access, and acceptability. After completing her PhD in HIV vaccine immunology, she conducted postdoctoral research at the Worcester Institute in Philadelphia and was a senior immunologist in Professor Adrian Hill's group at the University of Oxford. In 2016, while on sabbatical, she worked with the vaccine biotech company Vaxart on tablet-based oral vaccines for a range of therapeutic and prophylactic vaccines. Dr. Pauline Patterson is an assistant professor in the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine in the UK, and she's a co-director of the Vaccine Confidence Project, which is really an international profile and work in this area. Dr. Patterson has been researching issues of public confidence in immunization since 2010, and she's co-led a recent study in England exploring parents of young children's experience of childhood vaccination during the pandemic and their COVID-19 vaccine acceptance. She's a member of the National Institute for Health Research, the Health Protection Research Unit in Immunization, and also works for Public Health England. Dr. Patterson has a PhD in epidemiology, an MBA, and MSc from Imperial College London. And our fourth speaker, Dr. Gaetan Thomas, is a postdoctoral fellow at the Centre de Sociologie des Organisations, a collaborative unit between Sciences Po and the CNRS. He's also associated with the Media Lab at Sciences Po in Paris. He previously taught social sciences of health, I should say, at the École des Hautes Études en Sciences Sociales. And his doctoral research studied the history of epidemiology and vaccination in France during the second half of the 20th century. He held a Fulbright grant at Columbia University's Mailman School of Public Health as part of this research. His PhD project, was awarded the Alain Desrosiers Prize for outstanding contribution to the history of statistics. And in addition to publications in the history of medicine and science, he has edited and translated into French two prominent American critics associated with the cultural history of AIDS, Douglas Crimp and Craig Owens. Thank you very much, all of you, for participating. And in fact, we're going to start with Gaëtan, who's going to give us a perspective on vaccine acceptance and hesitancy in France. So Gaëtan, over to you. And I think you have some slides you're going to share with us as well.
I do, yeah. Thank you for, well, first, thank you for inviting me to join this panel. Can you hear me?
Yes. Mm-hmm.
Yeah. So, yeah, I'm just going to start to open my slides. Oh, sorry. Oops. Hi. Strangely, it's not happening. Oh, I'm sorry. Are you sure I can share my slides? Yeah.
Jennifer, if you're able to run the slide presentation yourself, perhaps.
Okay. Thank you.
There we go.
I'm sorry for this technical. So yeah, so thank you for the invitation. So I'm going to talk from the perspective of my historical research on immunization. So it might be a bit frustrating because I'm not really going to talk about acceptance as such, but more as a metric, acceptability, the way it's measured and the importance it has taken in the last decade, especially. So, let's start with this map that is very well known, that has been very influential in France among experts and the media, and that was produced by the Vaccine Confidence Project and published in 2016. That shows that France has the worst level of vaccine confidence regarding safety of vaccines. And over the last year, when one would get a question from journalists or from anyone interested in immunization, that would be the first question. So what's the problem with France? Why is the country of Pasteur in such a situation regarding immunization? And it's always been very difficult for me to answer this question, not only because my doctoral research, my previous research on immunization dealt with a period that ended in the 1990s, and well, my knowledge regarding the present is limited, but also because when you look at the actual coverage rate, it doesn't look as dramatic as the confidence, the surveys on confidence could indicate. So, there is indeed a problem of perception, but it's one of the last syntheses that you can find on the website of the National Public Health Agency regarding coverage rates at the age of 2. And it's, even in the years of that were considered very problematic regarding vaccine confidence in 2016, because the last results seems better, we were still in a good average of vaccine rates. So I'm not saying that in order to defend my country, but just I'm trying to, understand the relationship between the measure of confidence and the importance that is given to this measure in relationship with the measure of vaccine coverage rates, and how the measure of confidence that became the kind of definitive metrics of the last decade. So measuring confidence or acceptability is not at all new in the field of immunization. And even before it became a metric, it was already a very important concern. And you can see, for instance, in the work on vaccine schedules or combined vaccine, or the ideal or the notion of acceptability was central in the work of people working on vaccines before the first surveys in the mid-1950s. So in the mid-1950s, when there was the arrival of the vaccine against polio, it's quite well known in the United States, a series of surveys where a commission from major figures of sociology at Columbia University and also at the Gallup Institute. And for more than 10 years, academic articles were published on the acceptability of the polio vaccine in the United States. In France, the first survey I could find in my archives was published in the mid-1960s, and it was on the acceptability of the BCG vaccine, the vaccine against tuberculosis. And you know, at this time in France, vaccine acceptability was not considered an issue, and actually it was not considered an issue until the 1990s. So there was globally also, like in general, vaccine acceptability was quite high, but the acceptability of the vaccine against tuberculosis was considered not as ideal as expected. So there was this survey that was produced, but it was the metric was quite rare at the time. And in the 1960s, 1970s, I couldn't find many instances of studies on acceptability. And I think a very important field for acceptability studies at this time was the field of family planning. And if you're interested in this issue, because family planning was also, in a way, a matter of prevention. And you can see how the notion of acceptance and acceptability is very often related, at least in the 1950s, 1960s, 1970s, to prophylactics. Or because, of course, you're offering people technology that they do not necessarily consider to be essential when it's presented to them. So you need to take into account their subjectivity. So the other important field for acceptability was in the 1970s, family planning. And I'm also saying, and so I'm referring to this book, Michelle Murphy's book on Decolonization of Life, and there are very important and interesting chapters on acceptability studies in the field of family planning. And because you can see also that in the 1970s, there was already a globalization of these metrics, because the WHO created a group on the acceptability of family planning, and concomitantly, there was the rise of a feminist critique of acceptability studies, something that you don't see in the field of immunization, but there was a very critical take on that kind of studies, and well, for different reasons, because mostly acceptability studies were carried out in the global south, in Bangladesh, in India. So there were a power issue that were obvious that we do not necessarily see in the field of immunization when the studies are carried in the north. So it was very dynamic in the 1970s in the field of family planning. And in France, you don't see instances of acceptability studies until the mid-1980s. And suddenly there's a renewed interest in acceptability studies in France in the 1980s. And I think for one main reason, at this time, there was a change of doctrine regarding obligation and legal coercion. In the mid-1980s, it was thought that voting new law for making immunization mandatory was counterproductive. So there was no project of canceling the previous law, but there was the idea that the vaccine against measles, the vaccine against all the new vaccine of the 1980s and this vaccine of the 1990s shouldn't be mandatory. So if there is if the power of the law is lacking, then you have to understand the subjectivity of people, because it's a negotiation. So suddenly the field became much more active. And at this time, very interestingly and differently from now, the notion of acceptability was not, how can I say that? Right now, the notion of acceptability creates some anxiety among public health experts and the media, because the answers are very often indeed quite bad when you look at the global picture, and especially in France. It was already the case in the 1980s, but the analysis was very different. So for different reasons. One of the reasons is that at this time, in the 1980s in France at least, the measure of the actual vaccine coverage rate was very bad. Actually, no one knew exactly what was the coverage rate for the most common immunization, vaccination. So there was a general sense that it was good, but there was not the pressure of reaching a very specific threshold. And in addition to that, so you see in this publication from the 1980s, you see the estimated coverage rates, and they are not bad, but they are not better than they are today. So, vaccine against tuberculosis between 60 and 85, it was a mandatory vaccine at the time. So, so those studies, they were not interpreted as bad, even though the result was not that great, in particular because the measure of the vaccine coverage rate was not very specific. And in addition to that, the global ideal rates were not as high as they are today. So for instance, in the 1980s, that was a very important decade for the expanded program on immunization. That was the program set up by the WHO in 1974. And in the 1980s, an ideal coverage rate, it was a convention, and it was a political convention mostly, was 80%, which is quite low. So there was the impression, that even with low, not ideal acceptability, because the vaccine coverage rate was not that difficult to reach, the situation was quite good. So obviously, between the 1980s, where there was a general sense that everything was going well, despite the rate that were not that great from our current perspective, things have changed. In the 1980s, you had this major crisis in France, major health crisis, plural, including the Hepatitis B vaccine crisis, and then in the 2000s, the H1N1 vaccination campaign failure, which was not limited to France. So the world perspective on those data has changed. So when I think experts and the media and people in general have higher expectations because they have experienced all those crises, and also because the metrics are more specific, are more accurate. So I'm just would like to invite you, to put, as I trying to do, to put the history of this metric in perspective to see how we react to them differently in various decades. So
thank you, Gaëtan. Thank you very much. Yeah, there's a number of questions to pursue there, and we'll have a chance to come back to them. But obviously, one of the major issues is what is the threshold? What is the target? What is a reasonable level of expectation? That question, I think, is a durable one that we'll come back to. I'd like to move on now to Pauline and to hear more about your work as part of the vaccine acceptance project in the UK. Thanks, Pauline.
Can you hear me okay? Yeah.
Great. Yes, indeed.
Great, thank you. Great. So at the Vaccine Confidence Project, we developed a vaccine confidence index to track public trust in vaccines around the globe. And we use 4 key components for this. Overall, I think vaccines are important. Overall, I think vaccines are safe. Overall, vaccines are effective. And vaccines are compatible with my religious beliefs. And what you see here is you see a survey we conducted with over 284,000 individuals in 149 countries. And the change from 2015 to 2018. And as Gaëtan was saying, so France is dark orange. It's one of the places where people are less likely to think that vaccines are safe, let's say. And we did this on a Likert scale from strongly agree, tend to disagree, strongly disagree. And as you can see, so public confidence in vaccines varies widely between these countries. And although in the first survey in 2015, we saw that the European region was low, what we've seen in 2018 is that confidence has been improving in some member states in the Euro region, and these are include France, Italy, Ireland, and Finland. But what can this survey do? Because it's a simple survey. It's a quick. It's 4 questions. But what it can do is, because of this, you can run it globally and you can run it yearly or more often, and it can give you an indication of how your country is doing to other countries, and also see, have there been any dips in confidence, and is there anything you need to look into? And also countries can see how they're doing compared to other countries. And as well as that, you can kind of get an idea if there's a new, so for example, with COVID, where are we starting from? What's the ground like at the moment? What is confidence in vaccines generally? Because then it might give you an indication of what might happen and how people might feel with a new vaccine. Although vaccine hesitancy has been shown to be very context specific. So although we're looking at countries here, you really do need to have a deeper dive to look at specific populations, specific groups, and confidence hesitancy varies by time, by vaccine, by subpopulation. And when we talk about vaccine hesitancy, the Strategic Advisory Group of Experts on Vaccine Hesitancy define it as a delay in acceptance or refusal of vaccines despite availability of vaccine services. The European Union also commissioned us to run a survey in the EU, and here we did a survey with 28 EU member states with over 28,000 individuals and 1,000 general practitioners, doctors in 10 countries. And what you can see here in the maps are vaccines are important for children to have on the left, and overall I think vaccines are safe. And dark is that people are agreeing. And the majority of the EU public do agree that vaccines are important. That was 90%. Vaccines are safe, 82.8%. Vaccines are effective, 87.8%. Compatible with religious beliefs, that was at 78.5%. As part of the NIHR HPRU, so that's the National Institute for Health Research, Health Protection Research Unit in Immunization, we conducted a study with parents and guardians of young children. And the main reason for this study was to explore their experiences of vaccinating their child during the first wave of the pandemic, during the first lockdown in the England. And while we were surveying these parents, we thought, let's find out what their views are around acceptance around a vaccine. So back then we didn't know who the target groups would be for vaccination, but we thought, well, we're talking to these people, let's ask. And 90% were willing to accept a COVID vaccine when one became available for themselves. And the main reasons were to protect themselves, their family, others, to stay safe for their children, to stop the need for social distancing. The reasons they were less likely to accept the vaccine were concerns around safety, concerns around the vaccine being new, the disease being new, concerns around the process being rushed. Generally, it takes many, many years for vaccines to be developed. And here we're developing these vaccines faster than any other. So there are concerns there, concerns around not enough evidence. Or sometimes it's not that they don't want it, it's just that they feel that they're not in an at-risk group. So they don't want to accept it because they think, well, I don't need it. I'll leave that vaccine for other people. And there are some concerns around lack of effectiveness as well and lack of data on that. But 2 of the key findings were that people from Black, Asian, Chinese, mixed or other ethnicities were 3 times more likely to say that they wouldn't accept a vaccine, as well as people from lower income households as well. So this is a key finding that merits more in-depth research, although it's worth doing research on the populations that are currently being vaccinated rather than a group that's not. So as I said, the original purpose of that study was to explore views and experiences of accessing, and 1 in 4 people had issues of getting their child vaccinated. So in terms of difficulties in organizing the vaccine appointment, maybe there's a generic text message saying, don't come visit your GP, your general practitioner, they're closed, don't come visit. So some parents who had booked in the vaccine appointment were like, well, do I not go then? Are they closed? Like more those kind of confusions and lack of clarity. And also lack of, knowing what procedures would be in place that would keep them COVID safe and also their young child. But when parents did go vaccinate their child, they were really reassured with the procedures that were in place, and they reassured other people as well. With every epidemic, with every pandemic comes a lot of information. And with a lot of information also comes misinformation, rumors. Dr. Tedros Adhanom, the Director General of WHO, warned against an infodemic of rumors and misinformation that needs to be fought alongside this pandemic. And with the internet, with social media, individuals are more informed and empowered than ever before. However, they are also exposed to misinformation. With social media, with the internet, concerns can spread quickly. They can spread fast and far. And we did a study at the Vaccine Confidence Project with colleagues in other universities where we explored the effect of misinformation on people's acceptance of a COVID vaccine. This was looking at adults. And what we did find is that when you exposed members of the public to misinformation, they were then less likely to, less willing to accept a vaccine after that. So although most people don't trust the internet, our study and some other studies have shown that misinformation can cause concerns and make people less willing to accept a vaccine. And just briefly, just to finish, it is vital that vaccination campaigns not only ensure equitable distribution of vaccines according to need, but that government, public health officials and healthcare workers reassure the public with transparency, accountability and timeliness. It's really key to listen and engage with stakeholders and the public. So not just to communicate out, but also to listen to what are the concerns, what are the questions. Let's answer those questions. Let's answer those concerns. Let's reassure the public. And yeah, that's it for me. Thank you. I look forward to the discussion.
Thank you, Pauline. It's extremely helpful, and the work that your group has been doing is really quite extraordinary and deserving of that reputation as having kind of world-leading approach. And it's great to see that you're partnering with all sorts of different agencies that want to commission research and take it forward. We're now going to turn to Anita, and for a different perspective, you're based in the Netherlands, but actually, I think it would be very helpful actually to get your perspective as a medical anthropologist and somebody who's looking really at this wider question of how do we tackle this phenomenon, not just as one of public health and of messaging, but as something more intimately connected with belief patterns and human sociability in a certain kind of way. So I wonder if you could comment on that, Anita.
Yes, thank you. Thank you very much. And thank you also, Gaten and Pauline, really interesting contributions. I was so into your contribution, I forgot what I wanted to say. So I speak from my experience of working in global health. My anthropological studies have always focused on acceptance, actually, utilization of technologies in global health programs. So I've also worked on family planning. Gaten referred to family planning, and indeed that's been an area where there's been a lot of attention to acceptability studies. A lot that we can learn from that field for vaccination. I work very closely with people in public health who have, more than anthropologists, a tendency to want to fix things fast. And vaccines are a way of fixing epidemics, a way of fixing the COVID epidemic. So here we have this tool. I think, Anne, you said in the when we were chatting before this session, we have this tool. Can we now use it? And my colleagues ask anthropologists to find out what then the determinants are of hesitancy. So which people are hesitant, so that we can then target those people with more information and make sure they join up in the vaccination campaigns. So this approach of finding determinants of acceptability is always key in global health programs. It seemed to be an important way of solving an acceptability problem of any technology, including vaccinations. But there was an interesting review of published literature on hesitancy in 2012, and it found that it's very hard to find these determinants for vaccine hesitancy. And indeed, we've done studies on vaccination acceptance, that's what we called it at the time, in several countries, including the Netherlands, but also Bangladesh, the Philippines. And it's very hard to determine who are the people who are hesitant. So I'd like to share some key insights from anthropology from this work that I've been engaging in. And one is that vaccine hesitancy comes in very many different forms. So there are many reasons to be hesitant. And actually, the challenge is I think Pauline, you already said, you really need to understand the stories. You need to understand the narratives. What is it that people are hesitant about? And as anthropologists, we do a close reading of such narratives, trying to understand their logic. Where are they coming from? There's always a logic. So it's not that people are just malinformed. There's usually something else going on. So if we look at just recent newspaper reports on the anti-vaxxers who disrupted a mass vaccination site in Los Angeles, that was really horrible to see. And at the same time in Los Angeles, a lot of health workers don't want to get vaccinated. They're hesitant. It's not that they don't want, they hesitate. So these are two really different groups. And just before coming up, I was talking to my 14-year-old niece who is here to do her schooling from our home so she doesn't bother her parents. And I asked her, do you know about any of your schoolmates who are hesitant? Yes, one of her friends. I asked why. And she said, she's worried something fertility. It's a completely different form of hesitancy. Pregnant women, women who still want to become pregnant, they're hesitant. So these different narratives really need to be understood. And what anthropology does is provide a close reading of those different narratives and really try to understand that. And when you close read these narratives, you have to understand them in context. The problem with context is not localized anymore. So the concern of the friend of my niece about fertility is something that she picked up through the internet. This is a globalized narrative. So we need to understand these narratives, different kinds of narratives of hesitancy in relation to the context in which they emerge, and those contexts are also global information spaces. So as anthropologists, we're turning more to do what we call virtual ethnography, which is really reading closely again these narratives virtually. And there's also all kinds of tools from digital humanities that you can use to examine these kinds of narratives. Often they're just examined for whether they're negative or positive, but we propose to go more in depth to really understand those narratives, what is being said there. A second point about hesitancy is that it's dynamic. It's always changing. So here in the Netherlands, we started off with real concerns about of hesitancy about the COVID-19 vaccine. 50%, 60% of people who were surveyed, and we have this 6-week survey. Every 6 weeks we do a kind of survey, and 60% were hesitant about the vaccine. And I sit on the board of the National Institute of Health, and we were seriously concerned. What are we going to do about this other 40%? And then when the vaccines came over Christmas and there were shortages, the vaccination acceptance rates went up to 80%, just 20%, just like that in a few weeks. So they went up. But similarly, the acceptance, the tendency to accept a vaccination is fragile. So when I was doing field work, still on family planning, I did work on anti-fertility vaccines. They were being developed at the time. And I was seriously concerned actually about anti-fertility vaccines because the concern from a women's health, medical anthropology and women's health perspective was they might have long-lasting effects on fertility. So we had a fertility concern. To my surprise, when I started working on acceptability of vaccinations, there were major concerns about fertility, which somehow echoed these concerns about the anti-fertility vaccines, but the concerns had moved to concerns about tetanus vaccination. So it's just a kind of mix-up, actually, of the messages. And people in different countries, this was before that we had internet and so rapid exchange of information, started opposing tetanus vaccines because of their fertility effects. And the Catholic Church and pro-life movements supported that in the Philippines, in Mexico, and in Tanzania, all over the place. And childhood vaccination rates in those countries actually went down. And this shows the fragility, the dynamic nature of vaccination, hesitancy and acceptance, and also the fragility. What do we learn from that? So on the one hand, there's so many different kinds of vaccination hesitancy. And on the other hand, it's dynamic. It can move in all kinds of directions kind of rapidly. This must be a real concern for people. Anne, you mentioned you want to develop vaccines, and here you are presenting something into a landscape that's so dynamic and so diverse. So how can we confront this dynamic and diverse nature of hesitancy and acceptance? And I think a way forward is, and I sit on the supervisory board of our National Institute of Health, and what I'm always saying is a way forward is to, well, not only do these kind of ethnographic studies and other kinds of studies so that we better have a feel for what's going on, but it's actually to work with this diversity and dynamic nature of vaccination hesitancy and engage with these different populations to understand what's going on, to really learn from them. So to not put them aside as misinformation and kind of unscientific, followed by rumors and kind of negative, but to listen why this friend of my niece is so concerned about her fertility. And what you learn when you listen is she's so concerned because fertility is very important to her. So vaccines people can be anxious about vaccines because they're healthy to start with. Another reason that you find out, another logic. So you're using a vaccine when you are healthy, first of all. So we need to understand these logics. What is it behind? And engage with those logics in co-creating, I think, programs of information. So it's not enough to just throw more information when there's kind of disinformation, but you actually have to co-create counter narratives that deal with the issues that are there. I think that kind of co-creation of understandings is a way to move, but you have to understand the diversity to start with. So I think I'll leave it at that right now. Very curious what kind of discussions we will.
Thank you very much, Anita. That was extremely helpful, and a number of really important points there. I think I found it really interesting, the emphasis on the close reading of narratives, but also, as you were saying just then, on engaging with people and of dialogue and of a certain kind of sympathy so that you understand in a more textured way what is prompting it rather than condemning it out of hand. Thank you very much. Anne, we're going to turn to you now, and very much looking forward to your contribution to thinking about an Irish context in particular, but obviously with a much wider application necessarily. So over to you.
Thanks very much, Dan. I think in the interest of time, because it would be good to keep as much time for discussion as possible, I'll probably say we'll skip through this quite a bit. So Jennifer, if you could go on to the next slide, please. And then click again. So this is, oh, sorry, yeah, that's it. This is an analysis from an Irish context of all the wonderful work that Pauline and Heidi and the group at the Vaccine Confidence Project in the London School have worked on. And this is an Irish context, and you can see in the, we have the 2018 figures in the top, and then the second row in white is the 2016 figures. And what you can see is that there is a slight decrease in vaccine confidence across those 4 to 6 questions that Pauline mentioned earlier. And further down in that kind of scrubby Excel sheet, you can see that it's very much linking with age. So the 35 to 44-year-old people in Ireland are the least confident, But overall, Ireland has quite high confidence levels in vaccines, in their safety, and in their importance to society in general. So can I have the next slide, please? And this is just to highlight that we do have very high levels of school immunization rates and childhood immunization rates. And then, as always, in the next slide, what we can see is that this is what always happens. This is a slide from the WHO when we have this kind of balancing of vaccine implementation and then society's reaction to vaccination. So at the left-hand side, we can see stage 1. This is kind of where we are at the moment. We're probably in stage 2, where we have a disease. The public are demanding a vaccine, and public health, and everybody knows that a vaccine is needed. And once a vaccine starts being used, we see levels of disease going down. After a certain amount of time, around called stage 3, we don't have disease anymore, but we're still vaccinating. And at this stage, different factors come into play, where people see the risk of a vaccine is the main risk as opposed to the risk of disease. And what you can see is a drop in the level of confidence, and then usually you will see an outbreak of disease, whether it's at the same time or delayed after that. And then there's a huge amount of work that needs to be done to resume that confidence in the vaccine as to why it's still needed, and why it's important for that vaccine to counter the disease and maintain health in everyone. And hopefully, eventually we get to stage 5, where we can actually eradicate the disease. And there's only one virus, smallpox, that's been eradicated through vaccination. We've done a lot of work globally on polio, and we're at an elimination stage and nearly eradication stage there. So that's generally what happens with vaccines. And if you click onto the next slide, you can see what has happened in Ireland, where I'm sure a lot of you remember what happened with HPV vaccines, which there was a really strong call to bring them in back in 2010. The Minister of Health was under a lot of pressure. We had very high rates of vaccination in adolescent girls, up to around 2017, when there was this almost outbreak of lack of confidence, and driven by some public people with responsibility in the public eye, and that dropped the vaccine uptake to about 51%. And it was through huge efforts by various people, both clinically, which you can see up the top, and also by really strong advocates from the public, such as Laura Brennan, whose story is so powerful, and almost single-handedly turned that vaccine immunization rates on the upward turn, and we're up to about 70% at this stage. And importantly, we now have boys being vaccinated as well. So at the time, and the next slide, we had a really talented PhD student who looked into this before 2017 and started asking parents as to what was listening to parents and doing focus groups and understanding what were the key determinants that swayed their decision when it comes to HPV vaccination for their adolescent daughters. And you can see a list of these here, both knowledge, attention, decision processes, beliefs about capabilities, about consequences, was it right or wrong to immunize their daughter, the emotion around it. And one of the factors that we zoned in on was knowledge. And in the next slide, you can see we carried out a preliminary intervention based on knowledge for parents and their daughters to see if knowledge would make a difference to their decision-making process around the HPV vaccine. This again was at the time when only girls were being vaccinated in Ireland. And we could show that there was a significant difference. When people had more knowledge, they were more inclined to make a positive decision about vaccinating their daughter. And then in the next slide, and actually I'll skip through that because that's what discourages vaccination. I think it's more important on the next slide to think about what encourages vaccination. And this kind of is, I suppose, a text version of what Anita and Gaetan and Pauline were mentioning. So it's about sources of reliable information, positive messages. Trust is a huge factor. Trust in institutions and providers. Healthcare providers, people working in the healthcare profession are a huge source of that people rely on to get information that they will believe and trust. Confidence in vaccines, confidence in the whole kind of industry as well as the environment around vaccines, encouragements by doctors and healthcare providers. Easy access is hugely important, and Pauline was mentioning that when it comes to COVID vaccine. Ease of administration, which for on a scientific side that we're very interested in doing, making needle-free versions of vaccines here in UCC, and targeting of high-risk groups as well. And I think what Anita was saying there very much so about listening to people. Their hesitancy is a real, it is a real thing, and people have genuine concerns as to why they're hesitant. And I think it is about listening and as Anita said, co-creating counter narratives and co-creating narratives that work and help people to make an informed decision. So on the next slide, I'll where to now, and all of this work is related to pre-COVID times, understanding the reasons for hesitancy. We can only generate reliable information and help people make the right decision if we understand what are the hesitant factors behind it, and find and test those interventions, as well as making vaccines the social norm. They are in most countries, but not everywhere, and also equipping healthcare professionals to empower them to give that information. In Ireland, healthcare professionals are, even in normal non-COVID times, are under a huge amount of time pressure, as well as a lot of other pressures, and providing them with easy resources that they can rely on to have that informed discussion with their patients and other people. Okay, and on that, I'll flick through the next slide, which is the thank you slide, and onto the final slide, which is the key areas where you can get information. In Ireland, the HSE now has very good information around vaccines, as well as the Health Products Regulatory Authority, which is the regulatory body in Ireland. And on that, I'll stop so we can get into discussion.
Thank you very much. That was extremely helpful. And bringing it home in that sense is really kind of crucial, obviously, at this moment in time. Could I ask you, Anna, an opening question, really just about the science side of it? What should we be aiming for? Not just in Ireland, of course, but what level of immunization is necessary? I've heard the figure of 80% of the population really needs to have received the vaccine. Is that the kind of figure that you as a scientist feel is necessary?
Yeah, I suppose the scientific answer is we don't know exactly what it is, but it is going to be likely around 70 to 80%. And especially at the moment where we're not vaccinating children in Ireland, that automatically brings our population down to about 85%. If we can vaccinate all the adults, then that will be a good outcome. But we don't actually know, and it may be context specific as well. Some areas may require higher levels of vaccine uptake compared to others.
And that's one of the interesting challenges here, because of course all of this is unfolding and we don't know what the relative degrees of success will be. Much has been promised, and naturally people hold on to those promises. If the promises aren't delivered, then we enter a different territory. And I think that speaks to a point that that really, in different ways, you were all emphasizing, but of the dynamic nature of the situation, that you can have a drop off of confidence and then suddenly a boost of confidence, that narratives come into play. So I wondered, Pauline, if you might comment on that, about what I think Anita and Anne in particular were emphasizing about the dynamic nature of this territory, if I can put it that way. Is that supported by your research?
Yes. And when I did show one survey that we did with these parents of young children, but I do have other slides, but I didn't have time. But yeah, the percentage of people who are willing to accept a vaccine has changed, and it changes. It depends on how you ask the question. It depends on what people have read that morning, or whether their grandmother's got ill, or what's happened to their friend. And it really does vary, and it is. The vaccine hesitancy is a bit of a bell curve. So on one side, you've got people who are very critical of vaccines, but there's not many of them, but they seem loud on the internet. They seem loud on social media. But most people are kind of in the middle. Like the majority of people, like we've seen, coverage is high in childhood vaccinations. The majority of people accept vaccines. And with COVID vaccination, the majority of people who are in at-risk groups want to vaccinate, and they're waiting to get their letter, to get their call to say they can go get vaccinated. But there are some people who can be swayed, some people in the middle who can be swayed by misinformation, who can be swayed towards being a bit more critical or maybe not so accepting. And I think with this disease, it's affected people so much. People have changed their lives because of COVID. So there is a want for this vaccine to reduce the need for social distancing, to get back to normal. But also, these are new vaccines. We don't know how effective they are. We don't know if they reduce transmission. We don't know how long they're going to last. So there's all of this balancing going on in people's heads when they're making a decision whether to vaccinate or not.
Yeah, I was intrigued by the idea that scarcity might promote people's desire.
Yes.
So this is a new technique, perhaps, to achieve this goal. Perhaps not the intended policy, but interesting implications. Gaëtan, I want to ask you a question about something that came up in your presentation, which was whether you make vaccines a matter of law. And there clearly is a lot of hesitation in Europe, and not alone in Europe. But I just wondered about your research and your take on that, about why it seems to be a bad idea to say, right, you're doing this or else, jail time or whatever it might be. So, could you comment on that?
Well, like hesitancy, there is a lot of change. So in the 1980s, there was this idea that the law was not the right tool to increase in vaccination coverage. And particularly because after the eradication of smallpox, it took some time in France and in other countries to stop the vaccination against smallpox because it wasn't written into the law. So the law was considered to be, the temporality of the law, of making the law, was considered to be not appropriate when people were talking about immunization. One had to find a more flexible tool than the law. But that has changed in the last decade in France because so many like most of the childhood immunization are now mandatory. And I did to my understanding right now is that it's because France is not going to make this vaccine mandatory, the COVID vaccines mandatory for now because they are too new, but it's not excluded that at some point they would become mandatory because laws become again so popular. And I did some interview with public health officials, and it's just because right now the vaccines are new, but they could be made mandatory in a very near future.
Well, that's very interesting that it might be part of a timeline in effect. That's interesting. Anita, you've obviously worked on a lot of these questions in a global context. What's your view on the legal enforcement, in a sense, of vaccines?
Yeah, I would say that from my comparative studies, vaccination acceptance tends to be really high. We had several sites in Africa, and you could see also from Pauline's maps, vaccination acceptance is already high. And if a state would then make it mandatory, I think it could really create resistance. Yeah. So where there's power, there's resistance. This is what anthropology teaches you. Mm-hmm. So I'd be very careful with that. And also, I'm very sure in the Netherlands that here, if we would have mandatory vaccination, there would be maybe more riots. I don't think that would work here.
Well, I think you're quite right. It could get connected with other forms of opposition, which
yeah. And so this was also a point that I think Anne made, that it's so important that people's levels of acceptance also have to do with their trust in the institutions that are providing these technologies. So this is also a fragility if there's a problem in the trust, or if the institutions have a bad track record, you could be in trouble. Childhood vaccination is done in mother and child clinics in many countries, and they tend to be trusted. So there's a lot of acceptance of childhood vaccinations there, but it's fragile.
Yeah. There's an interesting question has come in, which I'll read out, and something for us to reflect on. The vaccine is dependent on altruistic behavior as people take vaccine to help the at-risk persons and reduce intensive care levels. I mean, that's certainly part of it. Many see the vaccine as a self-centered solution to allow travel. How will confidence in the vaccine to protect others be assured, especially when it does not remove the behavior measures, masking distances, and hygiene? I mean, that's a complicated question and difficult to pull apart. I guess it speaks to that question of motivation and how do you entice people to take a vaccine? Is it essentially a self-interested argument, or is it one which is predicated on altruism in some sense? I don't know, Pauline, whether that's something have you worked at that level of almost the psychological motivation and what seems to work within an acceptance framework?
Yeah, it's a really interesting question and a really interesting point. And I think we can compare kind of a bit with the flu vaccine, because with flu vaccine, some members of the public, but also healthcare providers, they vaccinate to protect members of the public. So, for example, and if you communicate to the healthcare professionals that the reason for them to get vaccinated is to protect the public, so it's more of a protective, more of a kind of that side of it, they're more inclined to get vaccinated, especially for healthcare providers that don't feel at risk of severe flu or don't feel like they're vulnerable to being severely ill and from flu. But here, the issue here with COVID vaccine as well is that we don't know how well the vaccines prevent transmission. So in our surveys and in studies, there has been shown that people are more willing to get vaccinated if they've got members of the family that are vulnerable or in at-risk groups to protect their community. So there is that side of it, and definitely that people are willing to help others, but there is this issue, and I think it was Anne or Anita who said that with vaccines compared to with medicines, you're vaccinating someone who's healthy generally. And it'll depend on the strategy. Sorry, this answer is very complex, but the question is complex as well. And in the UK, the strategy at the moment is generally to be vaccinating those in the at-risk groups as to protect them. Whereas in the future, who knows whether there has been talk potentially of vaccinating children to protect others. I mean, it depends who are the transmitters, and it depends, like at the beginning of the pandemic, it didn't look like children were the transmitters, but who knows if that's going to change or not as well. So I think this is dynamic as well.
Yeah. Anita, I think you wanted to come in there.
Yeah. So the way we also view this is in terms of a history of how public health has been developing. And in public health is, I'm not sure in Ireland, but in many countries has been defunded, and there's much less attention to this common good of public health. So much of public health has actually been individualized. You look after yourself. So through that kind of trend, that neoliberal trend, we've kind of made people who are responsible for themselves, and now we're asking them to be responsible for the collective. So I think it also needs a rethinking, a resetting in a way of public health.
That is an extremely important point, and I think there are many of discoveries are being made, but that I think is pretty high up on the list. And it's interesting, of course, in the UK, there's been a strong emphasis on protecting the NHS, so that becomes this rallying call. We can summon public moral energy around an institution, which is really fascinating to see that. But other countries, there's different healthcare systems. Some of which are more fragmented, some private and public, and so on and so forth. That's a different scenario. But it does also, I think, speak to the fact that COVID-19 is really about the order of values. I think that's my own personal view. It's ultimately about that. It's also about many other things and science and so forth. Yeah, I wonder if we could, there's an interesting point actually that's come in. I wanted to reference that one of our attendees was saying, I get anxious when I see a video of elderly celebrities getting vaccinated with the aim of showing that they are safe. The reason the person goes on to say is that because elderly people can die of other causes, if people then link the fact that they have graciously volunteered to present themselves for vaccination and yet expire within some short order, this may be counterproductive. I suppose another illustration of how challenging this, the situation can be, if I can put it that way. I wanted to ask about an area that's I'm curious about, where I've read some stories about vaccine hesitancy amongst healthcare workers, both nurses, public health officials, doctors, and why that might be. It does seem awfully paradoxical, but I don't know whether Pauline or Anne, you have any thoughts on that. Is that, I mean, that these are in the newspaper context or online sources, whether you would validate that as a source of an issue, but I'm not altogether clear on why people working in the healthcare system would be those who are disinclined, if I can put it that way, to be vaccinated. Do you have any thoughts on that, Anne?
Yes, well, I guess people working in the healthcare environment have a different risk attitude to general disease as a kind of baseline. And I mean, in studies and interviews we've had with nurses and doctors, they all know that say a flu vaccine is a good thing to do, and they know that if they're hesitant, they almost apologize for it, but they still won't get it. And it is a big area of, I think it does kind of come back. I mean, Pauline will probably have some comments on this as well. It comes back to, they're working in a disease environment every day, and they just feel that, it'll be okay, I didn't get it last year, and it made me sick last year, and things like that. You hear that quite frequently. I guess another thing is the convenience of it as well. In some Irish hospitals and healthcare environments, booking that appointment with the occupational health traditionally, now it has changed the last 2 or 3 years, has been quite difficult. So we've had low levels of immunization in our healthcare professionals because of that. That has changed in the last 2 or 3 years, though. Maybe Pauline has probably other points to make as well.
Yeah, thank you. So we're currently in the process of conducting a survey and interviews with health and social care workers in the UK. And so we're currently analysing the data, so I don't have any yet to share, but it's not, speaking with friends, colleagues also, yeah, there is that access issue. So I had a colleague who was trying to book, the system was crashing, or it's in 2 weeks, and that uncertainty about that second dose as well, and when that's going to happen. So there is some issues about the dosing schedules that's been changed, but yeah.
Sorry, Pauline, do you see similar issues from flu kind of coming into COVID vaccines, or is it do they have different perceptions?
I think so. You do see a bit of overlap between vaccines, but also each vaccine is very context specific. So I think as well with the COVID now, there's so much PPE and social distancing and everything else going on that maybe there are some people who think, well, I don't need the vaccine if I've got all of these other things, and I need to do those anyway, possibly. Or but yeah, it's watch this space. We're going to have some results soon.
Thank you. We're sort of coming towards the end of our time, but just a couple of other quick things I want to ask about. Gaetan, I was interested in something which came up in the context of the discussion of religious reasons why people might hesitate. And I think, France, partly as by European standards, quite a secular society. I wonder whether the religious values or things understood to be religious values come into play in any aspects of French concerns, or is it really a different kind of driver there?
So I haven't conducted surveys as the Confidence Project does, so I cannot say about what's happening right now. And indeed, it's quite, religion is not really accepted in the public debate. It's very problematic. It's very tense. But historically, no, it was never considered, until the 1980s, vaccine hesitancy or vaccine acceptability was never a public health issue in France. So, and there was a sense in the surveys conducted in the 1980s that maybe there was the beginning of a decrease of trust, but that was not significant. And public health experts didn't anticipate the crisis of the 1990s. And they were denying the influence of the anti-vaccine people, of the ecological movements, and obviously of the religious movement, which were quite inexistent in the public sphere. So it's never been a major concern. I don't think it is right now either.
Yeah, that in itself, I think, is very interesting, because I suppose, and presumably in Ireland, in the context of HPV, was partly a religious sensibility was coming into play, I take it, in relation to some.
Well, there was a fairly outspoken bishop, I think he was Waterford or Wexford, who made comments about the HPV vaccine. And it is, the HPV vaccine has been very much, it's called a cervical cancer vaccine. So it is very, in international studies, it's very much related to daughters not having sex. So it's kind of, well, if my daughter isn't going to have sex, then, she's going to stay pure, and therefore I don't need to vaccinate her. And I think there is this sort of issue. And again, it depends on what age children are vaccinated with HPV as to, it does come in for the HPV vaccine, it comes into it. Whereas really what it is it's a vaccine that prevents against a virus infection. So I think the initial kind of almost marketing around that vaccine may actually have been a disadvantage to that to that particular vaccine. So, and you can see this in some countries in Africa as well. This whole, you know, the purity of my child will never go, therefore they don't need this vaccine. And you have a lot of counter arguments to that as well, that my daughter will, you know, will have sex, and therefore she does need to be protected.
Yeah. This is one amongst the many issues. We've covered so much ground in a short period of time. I think we should come to a conclusion here in the interest of time, but I wanted to thank you all very much for an extremely interesting and insightful discussion, and a really necessary one at the current time. We're all struggling with the challenges, of course, as we talked about at the beginning, of the practicalities of making a vaccine available and the rollout and manufacture, et cetera. But really, ultimately, it's about how it sits within the society itself, and how we, not only in Ireland, but in a European context and a world context, try to collectively draw on the resources that are available to us in defeating an extremely difficult and intractable disease. So thank you all very much again for participating today. And the recording of today's discussion will be available on the Royal Irish Academy website. Our next session, coming up on the 25th of this month, is on COVID-19 and the arts. So we're looking at the future of the arts. So we're going to be looking at a different domain there where the impact has been enormous. Thank you again, everybody in the audience, for joining us. And so that's all for today. Thank you.
Thank you, Dan.
Thank you.
Thank you.
Thank you, everyone.